All right, well, let's talk about osteoarthritis. The great thing about this is that this is simple. This is not complex from a pharmacotherapy perspective or even from a pharmacology perspective. So what we're gonna just do is kind of talk about treatment goals. We're gonna talk about the mechanism of action of the drugs and talk about common adverse effects and talk about the role of topical therapies. And really kind of with that, it's gonna be focusing a lot on really what kind of joints are appropriate for the use of some of those topical therapies. So we'll start with a little bit of a case, and we're gonna put this case kind of a little bit all throughout. So we have OA is a 37-year-old female, presents with pain and swelling in the knee after years of playing competitive soccer. She's diagnosed with moderate osteoarthritis. She has no concurrent medical conditions. Okay, so no real past medical history, no current meds, no other conditions. So kind of a clean slate. We're very lucky. Got nothing else going on, right? So when it comes to treatments, everything's kind of wide open. When we think about osteoarthritis, as you've gone through all of your patho, right? This is where we think about that bone-on-bone kind of stuff, where you have that bone remodeling, that osteophyte formation, and that synovial inflammation. But our treatment approach obviously is going to be very different versus when we think about something like rheumatoid arthritis, where we have overwhelming inflammatory response. And with rheumatoid arthritis, we're going to be thinking about those disease-modifying agents, right? So things that are going to impact inflammation, like things that could be even potential like chemotherapy agents or anti-interleukin agents, anti-cytokine agents, all the kind of things that we see on TV where they talk about the infusions and making sure you've never had TB or hepatitis and all of that kind of stuff, right? Not the kind of stuff that we're going to be using for osteoarthritis. So it really brings us to what are we going to be thinking about as far as treatment and our goals of therapy. There's really nothing that we're going to be able to do that's going to kind of reverse what's already happened. So our first real goal is going to be to try and reduce the pain. This hurts. Anyone that's ever had osteoarthritis knows this hurts a lot. We're going to try to optimize their function. So get back to that quality of life, get back to what you want to be doing, and modify the process of that joint damage. So if there is some inflammation, can we decrease that? And is there a way we can decrease the weight of the joint, weight on that joint to slow any further damage? So can we kind of halt further damage a little bit? But really, we're just gonna kind of be focusing on symptom management. So how can we make things better and kind of give you back a little bit more quality of life? And with that comes a whole lot of recommendations. So below are the guidelines that were last published in 2020. And so what you can see here is a big old honk of stuff, right? So if we start with non-pharmacologic things, there's a whole lot listed there. And you start with your dark green, strongly recommended, if I can use the mouse, strongly recommended to conditionally recommended, and it's all kind of broken down by hand, knee, and hip, right? Because obviously we think about certain things that we can maybe do for the hand, especially topical things or local things for larger joints might not be as relevant or easy to do. So you have everything there from exercise to weight loss. Obviously, weight loss is kind of hard. Weight loss to have a real impact on the wrist, right, on the hand. But definitely for the hips and the knees, all the way down to things like even paraffin waxes. And that's what's kind of hysterical, right? There's even data on paraffin wax. Like, go get your manicure, paraffin wax for your hands. So we have data on some of that stuff. We can also kind of look here to the right and just even down to psychosocial mind-body approaches of things like acupuncture, thermal interventions, back down to your paraffin, cognitive behavioral therapy, all of those other things, and kind of weighing in a little bit more of what do we have about strongly recommending against, conditionally recommending against, and what do we have data to say, let's don't do this. So as you look at this, there's a lot that jumps out, at least for me, from the standpoint, we see a lot of patients that come to the emergency department with, my knee kills me, it's been hurting for the past 15 years, I have really bad arthritis in my knee, and today's the day that it hurts, and I come in. And we look, and you have really severe osteoarthritis of the knee. There is nothing acute that's changed. There's no effusion. There's no redness. There's no swelling. There's not an acute infection. We've looked behind. There's no DVT. There's no acute thing that has changed. There's not going to be a quick fix to this. When we look at what we can do, a lot of this, as we look, exercise, self-management programs, weight loss, Tai Chi, using a cane, all of these things are not things that we typically want to do a lot of times. A lot of times we tend to kind of want to do something and kind of get an intervention done really quickly and kind of see a result. And these are things that take a little bit more of an investment of time. And so if we think about that and we move towards our pharmacologic therapy, we have some options. Okay? So we have a strongly recommends again and a conditionally recommends. At the top of our list are oral NSAIDs. And then we have topical NSAIDs, intra-articular steroids, and then it kind of falls off a little bit. So as you notice here, is there anything that's not on the list that you would expect to be on the list? Anything that jumps out? Go ahead. Surgery, right? So again, as we kind of come up here, in our non-pharmacologic management, at some point we do get to joint replacement, right? But after we've kind of done all the things, right, and get to a certain point, any pharmacotherapy, any drug therapy that you don't see on there that you maybe would think patients would be opting for? Okay, what was that? Say that louder. Opiates. So do you see opioids on here at all? Right, so no opioids are listed here. We do have tramadol, and we can kind of use like a little asterisk kind of italicized around tramadol, and we'll talk about that. But we don't see morphine or oxycodone on here, right? And that's for good reason. And that's because we don't have great data on that. And we don't have data that show that long-term use of opioids really impact this. And that we don't have the outcomes that show that those are positive, have a good impact on the morbidity of these patients and actually could cause harm. So as we go through each of these interventions, these are kind of what we're going to touch on of what do we know about these interventions and what are we going to be thinking about with these. So we're going to start with our good old NSAIDs, right? So non-steroidal anti-inflammatory drugs. So how these work, right? We have some sort of insult, tissue damage, where we have that membrane phospholipid, which is then metabolized by phospholipase A down to arachidonic acid. That arachidonic acid then gets metabolized and transformed by cyclooxygenase, cyclooxygenase 1, and we have cyclooxygenase 2, to different prostaglandins. Now those prostaglandins, we have lots of different ones, like, right, PG1, 2, A, H, you name it, we've got one, right? But to keep things simple, we can kind of divide them into two categories, right? We can have protective ones and inflammatory ones. Cyclooxygenase 1 is going to break down to our protective ones. So these are our prostaglandins. Think about those that are going to protect our gastric mucosa, right? They make our protective lining in the stomach, and they help keep our platelets sticky, right? So protective, right? Cyclooxygenase 2, that's going to be our inflammatory one. So those are the ones that are going to cause inflammation, cause pain, cause an increase in temperature. Okay. So if I'm going to design a drug, and I want a drug that's going to treat inflammation, pain, fever, what would you want it to hit? Cyclooxygenase 2, right? Okay, as you've learned all about your drugs, we can't have nice things, right? Can't have nice things. So NSAIDs, prototype, first one we had, salicylic acid, right? So salicylic acid, get that. It box, cyclooxygenase 1 and cyclooxygenase 2, right? So every drug that you're ever going to prescribe, we balance two things, right? Safety and efficacy. So from an efficacy standpoint, we're looking at that inflammation, right? Blocking inflammation, blocking pain, and blocking that fever, right? So from a safety standpoint, we block cyclooxygenase 1, right? So what are you going to be worried about from a safety standpoint, just from that mechanism of action? What do you think? If I'm blocking cyclooxygenase 1. Bleeding, so one, bleeding. So if I'm affecting platelet stickiness, I could be at risk for bleeding. Damage to the stomach, damage to the gastric mucosa, so increased risk of gastric ulcers. Absolutely. So what do you think the main side effects we're going to worry about from NSAID use are? Upset stomach and ulcers and gastric ulcer formation, and we do worry about bleeding. So going to be your two big ones that we worry about. And so you know that already just from mechanism of action, right? Fantastic. So there's a lot of NSAIDs out there. And this chart just kind of goes through a couple of them. I've highlighted kind of the three common that you're probably going to see, but we got a ton out there. Most commonly, you're going to see ibuprofen, naproxen, and ketorolac. Ibuprofen and naproxen really your most common oral agents. Ketorolac is one you're most commonly going to see kind of from the clinical inside. So you can see that from clinics, you can see that from the hospital side, because it is your IV and your IM option. When we look at each of these, you have max daily doses. So with ibuprofen, generally 3.2 grams a day. With ketorolac, same thing, you have a max daily dose. With naproxen, you have a max daily dose. With ketorolac, you even have this little black box warning that says, one, short-term use, only 5 days worth. And it even says in there that really it should be given only after it was loaded intravenously or intramuscularly in an emergency setting, and that's based on how it was studied. But really, after it's been given IV or IM. And that's mainly because it has a wicked effect on the kidneys, a very profound effect, and so we're really limited in how long it can be used. Okay? So when we think about our pearls for NSAID use, NSAIDs generally have a ceiling effect. What's a dose ceiling effect? What does that mean? Yes?
Is it like there's only like a certain amount, like you can't, if you go higher than that ceiling effect, then it's not going to have any like effect?
Absolutely. So once we reach a certain dose, we can give more, but it doesn't really work any better. So as we look to here, we see with ibuprofen right there, it says 200 to 800 milligrams every 6 to 8 hours with a max of 3.2 milligrams a day with the max dose, 800 every 6 hours. And that's exactly what you'll see as the max dose. But we're smarter than that. So we have great clinical data that shows us when we compare 600 milligrams every 6 hours to 800 milligrams every 6 hours, what two things are we always balancing? Safety and efficacy. Efficacy, same thing. No better pain scores with 800 milligrams than with 600, okay? Safety, what do you think the difference is? Which one probably had worse side effects? Yep, bigger risk of GI bleeds and ulcers with 800 and more stomach upset with 800. So no different in efficacy, higher side effects. So most people would say, 600, you don't really get any more bang for your buck. So again, we generally have a ceiling effect. We have to be very, very careful in patients with renal dysfunction. Extreme caution is what I would say. In general, we would avoid it if at all possible. And that's because we know that NSAID use can decrease renal perfusion. This is not something that we want to use. So, all right, now let's take our 37-year-old soccer player. What if that 37-year-old soccer player is coming in and let's say she just ran a marathon and has a little bit of an AKI due to dehydration and her knee is absolutely killing her, it's swollen, it looks horrible, and she's in extreme pain. And we want to give her something, and we're talking about giving her an NSAID. Would that be a great idea? No, would not be a great idea, right? If she's got an acute kidney injury, absolutely would not be a great time to give her an NSAID and cause even more of an insult, right? So we want to avoid that in any patients that have renal dysfunction. Okay, so what about liver? Well, we want to avoid it in liver too, because patients that have liver dysfunction, we know they're at high risk for hepatorenal syndrome, right? So we don't want to do anything that then might mess up their kidneys, so we have to be very careful. So in general, I don't want to give NSAIDs to any patient with liver dysfunction, because again, that same decrease in renal perfusion could be enough to cause enough of a renal insult to cause a little bit of hepatorenal syndrome. We know that's not going to be a good thing. We have to think about their history. Does this patient have other risks for GI risk of an ulcer or GI bleeding in the past? So has this patient been on chronic steroids? Maybe they have really bad COPD and they get steroid burst about every 6 months or every 3 months. Maybe they have really bad Crohn's disease, again, and have been on bursts of steroids or other inflammatory diseases. Maybe they have alcohol use disorder and they have really high risk for peptic ulcer disease from that. There's lots of other risk factors. Any risk of GI bleeding, and you add an NSAID on top of that, that could be very detrimental. We mentioned GI upset in general. So GI upset is kind of one thing. Most drugs can cause a little to the stomach. NSAIDs definitely on an empty stomach, even in a patient that's robust and doesn't have any issues or history. If anyone's taken a good dose of ibuprofen before breakfast and then forgot to eat, knows that the gut rot can happen. So you want to take it with some food to avoid that. Okay? Now, we said we could be smart. So we said, if I really wanted to avoid all of that stuff and the ickiness, right, I would develop something that just inhibits cyclooxygenase 2. And we are smart. So in the late 90s, we said, we are so smart, we're going to do that, okay? So we developed the COX-2 inhibitors, and that first one was Celebrex, celecoxib, and then rofecoxib and valdecoxib. These specifically blocked cyclooxygenase 2. And so the goal of this was we get all of the effects of blocking inflammation, pain, and we avoid all that stuff about GI, right? Total win-win. Sounds great, right? What can't we have? We totally can't have nice things, right? So this is a great story to talk about marketing of drugs and how the pendulum can swing and how you have to be insanely careful as new drugs come to market. So there was great marketing for these, exceptional marketing for these. And if you think about this, you have a huge role. You have a lot of patients that have debilitating pain, that have GI bleeds, and that have ulcers, that this would be great for, okay? And so we start using it, and using it, and using it, and using it. And then in 2000, the makers of Vioxx, this rofecoxib, say, okay, we're going to publish this huge trial, the VIGOR trial. And what it looked at was GI-related adverse outcomes. And so they said, okay, this is great. We're going to compare this to rofecoxib. And they said, okay, let's look at the rate of ulcers. Look at that, much less, 1% versus 2% in the rofecoxib group versus naproxen. That's awesome. Look at complicated ulcers. That's awesome. Look at that. It's fantastic. That is great. Awesome, wonderful, wonderful. But, oh no, we kind of found something different here, didn't we? Vascular events. Patients in the rofecoxib group had a much higher rate of vascular events than in the naproxen group. And it was like, when all of this started to come out. And so if you want to read any fun timelines of things, these are great articles to kind of go through and look at. The links are there in your slides. it breaks down the timeline. The NPR timeline is hysterical because it's literally like the press release of this, of kind of how it all comes out. And so when this came out, what you can watch is a whole timeline of this is when we start to really look at what are the data and how are NSAIDs, and specifically COX-2 inhibitors, related to cardiovascular risk. And so all these patients that we just flooded with these COX-2 inhibitors, we're starting to say, well, hang on a second, and taking a step back. And so Pfizer and the company that makes Bextra also said, you know what, we're just gonna take these off the market. We're good. You don't have to tell us, we're just gonna take them off the market. Celebrex stayed on, and what they said is, you know what, we're gonna stay on, but what we recommend is do not use in patients with history of significant cardiovascular disease, strokes, MIs, and really in patients that are at high risk. And we should be using the lowest doses of NSAIDs possible for the least amount of time possible, which comes back to kind of from a common sense perspective, right? So this is a good example of kind of how things morph through time and how we have to think about things. So the one that we have now on the market is the Celebrex, the celecoxib, and that's kind of how we think about using it, is if we want someone to be on an NSAID and we anticipate that they're probably gonna be on this for a while, they have significant arthritic disease, and maybe they have some risk factors for ulcers, and they don't have any cardiovascular risk factors. It's not a bad option. It seems like a pretty good option for them. Okay? But it's a really cool story to go through and read, especially if you're interested in like medical history. It's fantastic. That's oral NSAIDs, yes.
So if acetaminophen has like a similar mechanism of action and it has like, it seems to have less like GI side effects, how come that like the oral NSAIDs is more strongly recommended than like acetaminophen?
We're gonna talk about acetaminophen in a hot second. Yes.
Sorry, when you say to kind of avoid NSAIDs in patients with cardiovascular disease, is that both COX-1 and COX-2 inhibitors?
Yes, so in general, even ibuprofen, the exception of that would obviously using low-dose aspirin for antiplatelet therapy. That's in its own venue. But even like long-term naproxen use, with all NSAID therapy, in general, in anyone, we would say lowest dose, shortest time possible. Double asterisks in any one patient with cardiovascular disease. And as you look through even some of those links, you can really get to, there's a lot of discussion about how safe even naproxen and other NSAIDs are in patients with cardiovascular disease, which is why we keep coming back to lowest dose for the shortest time possible and really kind of moving away from patients just taking NSAIDs every day just for preventative therapy and really focusing in on all of the other kind of non-pharmacologic things that we could do. And using things like topical NSAIDs and developing more topical things. So we have diclofenac, and it's available as a gel that's actually available over the counter. There are some higher percentages that are available as a prescription and even solutions that are available as a prescription. And these actually work really, really well. But you have to think about them from the perspective of where's your joint and where are things located? Obviously, things that are on the hand, if they're on the knees, where you can really kind of get in and kind of locate a specific place. If you're talking hip, that's a large area, which can also kind of radiate and have other things going on with it. Not a great option, but it's a great option for knees and hands. And it's really safer than oral therapy because you're getting minimal systemic absorption. So it's great, especially for patients that have any sort of risk for cardiovascular disease, renal dysfunction, as well as any sort of GI issues like those peptic ulcer disease. The dosing that you're gonna use is actually a scale on this little card, and it's based on the joint that you're gonna use, kind of either 2 grams or 4 grams. And the same thing kind of for the little solution. It's this little pump system of drops, like 40 drops that you can count. and then you rub it in. And there's even data with like using the drops in conjunction with things like lidocaine patches and trying to kind of put all these different multimodal therapies together with different therapies. So when it comes to these topical things like these topical NSAIDs, you want to make sure you think about where would be good places that you could actually put this on. Okay, so oral NSAIDs, topical NSAIDs. What about things like intra-articular injections? We can do these. Intra-articular steroids, used for most commonly the knee and the hip. Sometimes you can see them used for hand. A lot of times with hand, as we know, very small, very precise, and so you have to be very careful with those. A lot of times these are going to be limited, and there's conflicting data on this. There are data that show that you can get some cartilage damage with very frequent administration, very frequent injections. And there's conflicting data on how long these last. And a lot of this can be very patient dependent. These injections can be done sometimes just ultrasound guided. There's a lot that are now done via CT guided as well. So it depends on exactly where the injections need to take place as to kind of what type of equipment and guidance needs to be done with the injections. But a lot of times these can be temporizing things. So if you need something to get you over a little hump so that you can start physical therapy and start other things and start with the exercise, then again, it comes back to what is the plan for that symptom management and what is that next step? So intra-articular injections could be a possibility. Then we're kind of left with our conditional recommendations, which I kind of call potpourri. And this is just kind of like the smattering of all the other little things that we could think about. And let's talk about acetaminophen. So acetaminophen, when I was coming through school back a long time ago, acetaminophen 1 gram every 6 hours was like first-line therapy for osteoarthritis. And that's what you did. And now it is pretty much, we have data that says, yeah, it's probably no better than placebo and really doesn't do a whole lot. When it comes to outcomes and patients report, NSAIDs have much better outcomes. And that's kind of where we come back to why it's fallen so low in the treatment algorithm, is based off of our randomized control trial data and lack of outcomes. It was much higher because, in general, we thought, what harm? It's kind of one of those things of it's over the counter, how much harm could it happen? How much harm could it cause? Well, it can cause a lot of harm when we talk about overdosing. We'll talk a little bit about that. How does it work? One of my favorite mechanisms, like question mark, question mark, question mark. Everything we see kind of has stuff about maybe inhibiting prostaglandin synthesis, which then always makes me go back to, but then wouldn't it have some sort of anti-inflammatory effect, which we know it does not have any anti-inflammatory effect. So question mark, question mark, question mark of how it actually works. It does work. We know it does treat pain. It does reduce pain, doesn't reduce inflammation, but we know it does not have the outcome data that we see with other agents like our NSAIDs. But it doesn't increase the risk of peptic ulcer disease, so that's a good thing. But it's not effective when we use it alone. Perhaps when we use it with other interventions, we do see a bigger bang for our buck. When we think about how we dose it, generally we're talking 650 milligrams to 975 to a gram every 6 to 8 hours. You would use this in someone that couldn't use NSAIDs, but again, we know as monotherapy, it's not going to be great. Maybe combining this with topical would be an option. We worry most about hepatotoxicity. You will see differing data when it comes to the maximum daily dose. Per the package insert for McNeil, you will see 3 grams or 3.2 grams as the max daily dose. This is another good thing, kind of a medical history you can go down and go through a rabbit hole about. You will see through most of our medical literature and even through Lexicomp and everything else and what we would say and what I would say 4 grams. And so you will hear like wide variation thereof. And that's because if we look at any cough and cold aisle, right? When you walk up to it, every single thing that we have out there has Tylenol in it. Most everything out there has acetaminophen in it. So all those combination things and the ability to overdose is extremely high. Not intentionally, but accidentally. And when we do that, that's a bad thing because it's very, very easy to do. The way that we metabolize acetaminophen is we take acetaminophen in, right, goes to our liver. Some of it just gets excreted in the urine. The vast majority of it gets glucuronidated. Some of it goes through the cytochrome P450 system, 2E1, to this NAPQI, which is N-acetyl para-quata something, 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 NAPQI, all right? And then that is a toxic metabolite, but our body is awesome, so it actually gets conjugated with glutathione to a non-toxic metabolite, and then it goes away. So everything's great, right? Except when we either, one, chug the 5,000 count bottle. If we do that, then we overwhelm this system, and this says, I can't take it anymore, and we start pushing more metabolism this way. We build up that NAPQI, we start to cause some damage here, and we only have a certain amount of glutathione stores. So once we run out of those, this builds up and we start causing damage. Or I take 5 grams of acetaminophen a day for the past 3 weeks. And slowly over time, I slowly build this up and the same thing happens. So then you come and we treat this by giving you back glutathione so that you can metabolize this and get it out of your body. And we hope we do that before you've caused permanent damage to your liver. So in that setting, you can see why we would say, let's don't take a whole lot of it. And let's be cognizant of how much is out there. So that's our acetaminophen. Yes.
This is kind of a silly question, but
Silly.
for example, like the Tylenol for arthritis versus like Tylenol for headache or, drugs in general that are very specific. Is there really any difference like Tylenol for arthritis versus regular Tylenol?
That is actually a really, really good question. That is not a stupid question at all. So this Tylenol for arthritis you see listed here. What do you notice when you read this? Just read it out loud. Tylenol 8-hour, arthritis for pain, acetaminophen, extended release. So you're going to be an anal retentive pharmacist for a hot second. Extended release. If you just pull up acetaminophen like Walfen, Walgreens acetaminophen, it just says acetaminophen, extra strength, 500 milligram tablets. It doesn't say extended release. It's a big difference, right? Because normally you could give that regular release stuff every 4 to 6 hours. Okay? This is extended release. So this literally is going to slow release over this time frame. So yeah, 8 hours, this is different. So I have my Tylenol arthritis. Nana also has her Tylenol headache at home. She's got a migraine now, so she's gonna go grab her Tylenol migraine. She takes her Tylenol migraine and her Tylenol arthritis because of her back, because she's got arthritis in her back. And now I've got this and that on top of it. Yes, and it does make a difference because our release and our absorption is gonna be different. And if I overdose on my Tylenol extended release, now I have a different release time and can cause a whole host of other problems. So you're absolutely right, it does make a difference. You are 100% correct.
Why does our body make like NAPQI if it's so toxic? Like, what is the benefit of this?
Because our body is awesome in so many ways and so stupid in so many ways now. Because with all drugs, if we think about it, there's so many drugs that we do have that get metabolized, and some get metabolized to toxic metabolites. But our body has homeostasis, right? We're always in a balance. We have a way of getting rid of it, right? We have a way of getting rid of it. Unless we screw that up. And we screwed that up, right? We did something we shouldn't have done, and we took too much. And so if we think about it from that perspective, our body is gonna do whatever it takes to get itself back into balance. Now, whether or not we want it to is gonna be either the problem. Like either we don't want it to do what it wants to do, or we do want it to do, right? And so that's how I think about that, is that it's doing what it should do, right? But we screwed that up because we took too much. Does that make sense? Okay. That's how I always have to think from the homeostatic perspective, is that whatever we do, our body is going to try and fix. Sometimes that can mess us up even more, or sometimes we are better off to just let it work itself out. And we'll find that, and we find that in practice sometimes, is that we just need, because if we take out your ability to do something sometimes, we can make things 10 times worse. And sometimes we just need to give your body what it naturally needs and let it do its thing. All right, let's talk about the other potpourri. Let's talk about tramadol or Ultram. Tramadol is kind of in this bastardized class of things. It is considered an opioid, and that's because it does act on that mu receptor. It's an agonist on the mu receptor. But it's kind of like this bastardized opioid because it's an opioid, but not like an oxycodone opioid, because it also probably has an effect on norepinephrine and serotonin as well in the CNS. So it does some other things as well. You can use this also in patients that maybe can't tolerate other therapies, or they've tried NSAIDs and they're ineffective, or maybe NSAIDs work, but they're still not quite where they need to be. And this can be done on top of that, or PRN on top of scheduled NSAIDs for a short period of time. What we have to be careful of is patients that have a seizure disorder history. We want to avoid in those patients, but also high doses. And we want to be very careful in patients that are also on other serotonergic drugs. This is one of those drugs that we want to add to kind of our serotonin syndrome and serotonergic agents. And again, going to be very important with how often they're taking it. Okay. Our next is going to be duloxetine. Duloxetine can be used for lots of different things. It is a selective norepinephrine reuptake inhibitor plus a selective serotonin reuptake inhibitor. So it's an SSRI, SNRI combo drug. And as we've learned, as I'm sure you've learned kind of all throughout, most of our drugs that kind of work within the CNS, we've now learned we can probably work across a continuum of different indications. This you will see lots of patients on for different types of pain, as well as sometimes for anxiety and other mental health indications. But you can try this on patients who have failed NSAIDs, and really it does work well. A lot of times patients maybe titrate up to pretty significant doses on this, but it is a great option in some of those patients. So again, as part of that kind of potpourri option, getting further down. Good old topical capsaicin. It works, it does actually work. So it actually induces the release of substance P, and we know that is what gets released from that pain impulse. And what capsaicin will do is it's going to deplete the neuron of substance P and prevents that reaccumulation. What would you want to be careful about when you think about topical capsaicin? 90% of medicine is going to be common sense. If you're allergic, don't touch your eyes, right? So when you think about places to put capsaicin, where would be places you would think, not so great, let's don't do that. Yeah, your eyes, don't put it in your eyes. Let's just say that. Mouth, yeah. GU, yeah. Good news, we don't have a whole lot of arthritis in that area. Hands. Generally not a great one for hand arthritis. So yes, you have to, usually you have to apply it with your hands. But when you think about hand it's probably not the best place to leave it on. So even like applying it with gloves and taking it off. So, knees great, ankles, even sometimes kind of hip or back, you might be able to get there, but knees are good. Hands, not the best option there, just from the standpoint of the likelihood that you're gonna touch your face and your eyes. Even if it's just here and you do this, that's gonna be a big problem, right? What I love is the list of things that are just kind of meh, right? Even you'll see topical capsaicin is conditionally against, right? For hand, obviously, but strongly against all the other stuff. Like bisphosphonates, we know don't treat osteoarthritis. Our favorite glucosamine and chondroitin, right? What everyone wants to do, what everyone swears up and down, is gonna help. No, really doesn't. Your data's not great. You can spend $800 a month on it. Nope. Are things like hydroxychloroquine, methotrexate, TNF inhibitor, tumor necrosis factor inhibitors, interleukin inhibitors, again, that's rheumatoid arthritis, not gonna help. Stem cell injections, not gonna help. There's a lot of stuff looking at hyaluronic acid and PRP therapy, colchicine, non-tramadol opioids, fish oil, vitamin D. Vitamin D for everything, again, no data. I mean, it really don't have great data here with osteoarthritis. So again, we're back to NSAIDs, topical NSAIDs, acetaminophen, potpourri of some tramadol, duloxetine, maybe some intra-articular injections depending upon where they are and if they work. Maybe some capsaicin, but really using those things and getting to those non-pharmacologic things, getting to that exercise, to the weight loss, to the movement, to all of those other adjunctive therapies that unfortunately from a societal standpoint, from a healthcare standpoint, our system doesn't really afford us to be able to help people with. Yes?
What about CBD oil? I know people swear up and down about that.
Yeah, so what about CBD oil? So CBD oil is one of those things that I would love in the next, I have a feeling that by the time I retire, and God knows when, and you guys are up here teaching this to people, that will be like a whole host of itself and on its own. Because there are so many properties that likely will benefit and likely do have a benefit. There are some data that I've seen that look good. The problem that we have are the reproducibility and the specifications of exactly kind of which component. And that's where I don't know. Like, how do we do that? And you've had this one product and this one thing, and how do we then make that happen? And then how much of that is also, there is a significant placebo effect when it comes to all of these drugs for osteoarthritis, because you should be doing a lot of these things in combination therapy with some of those non-pharmacologic things. And so how much of it is really and truly the non-pharmacologic versus the pharmacologic therapy? But I truly think that by the time that y'all are teaching all of this, that's gonna be a whole other component. That's what I'm kind of banking on, because I do think that that's gonna be a lot of where everything comes from. Other questions?
So like you said in the beginning, it sounds like all these options are more for like symptom management. Do we have anything to help with like the actual mechanism of disease? Because I feel like it's only going to get worse if it's just bone on bone. And so are you just going to get a joint replacement eventually? It's just a matter of delaying when you get that?
Yeah, a lot of it may come down to which joint are we talking, and at some point a replacement. And a lot of that can get down to what's the age, and how can you mitigate some of the risk factors for really poor outcomes from a surgical perspective to ensure that you have a solidly good outcome. And that's where a lot of this kind of comes down to. And the unfortunate thing is, as you can see, these are the things that we, again, healthcare soapbox, that from a prescription standpoint, like you can say, I want you to exercise, I want you to go and do these things, I want you to get acupuncture, go to cognitive behavioral therapy, do these things, and no one's paying for that. But we will pay for the knee replacement and the PT that goes with that, but not the PT after that for the continued growth and weight loss and all of the things that we know that are gonna impact that, because then we're gonna have the complications afterwards and blah, 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 blah.
I saw that PRP was strongly against for knees and hip, but not for hand. What's the deal with not hand?
That's a very good question that there is no way in the world that I can answer that for you other than to look through the data that they put through for that in the guidelines. Other than, I think that the things that I've read about PRP as far as it's the numbers still from an outcome standpoint as far as how many patients they've still reported, I don't know if it's that or truly what the final outcome is of that, to be honest with you. I know we've done a lot, and that UNC has done a lot in their sports medicine clinic as well. A lot for elbows. I've seen a lot of PRP for elbows.
Is there such thing as like cartilage transplant or replacement? Like, is the only surgical option complete joint replacement? Or?
That's a really good question. I have no idea. I have absolutely no clue. I've never heard of that, but that means absolutely nothing, to be honest with you. I don't think so, but that, again, like I said, that doesn't mean anything. Mm-hmm. I'm sure there's a lab here somewhere that's building that. I have no doubt. There's a cartilage lab. So I got shark cartilage that they're like reconstructing. Yeah, like I have no doubt that there I'm sure there is. And like somewhere, like the censors just picked up some talk somewhere, and they said, "Oh my gosh, someone just asked about this, and you're going to be like flagged later." To do some research.
You're talking about a lack of efficacy for PRP. That's just specifically for osteoarthritis, right?
For osteoarthritis. Okay. We're only talking osteoarthritis, yeah. PRP is really cool. It's so cool. Yeah. Yeah, it is a really cool thing. My husband had it for his elbow. Yeah.
I just wanted to add, so this lecture kind of brings us all the way back to the beginning of our pharmacology lectures in terms of NSAIDs and acetaminophen. So both of those are, important. Acetaminophen is an important drug. NSAIDs are an important class of medications. When we think about how NSAIDs work, that's a really important concept to know, and some of the risks associated with long-term use of NSAIDs. And then going to acetaminophen, we used acetaminophen, and Jenny did the medical toxicology lecture, and one of those was a Tylenol overdose. When we think about the depletion of glutathione, the use of N-acetylcysteine to replace it, and then also when we get into looking at metabolism, phase 1 versus phase 2 metabolism. So, I can't stress that enough, because this will come up a lot in your clerkships. It's come up on your exams. Those are important things. When you study for the MBME as well, those are things that I highlight too, that you should really be focused in on, because acetaminophen in particular is just a great drug to highlight a lot of different things that we think about in practicing medicine, especially when we think about the differences in metabolic pathways, phase 1 and phase 2, and then a common overdose that they see a lot in the ED, that we see a lot on the floors, and how we manage it. And then same thing with NSAIDs and even looking at COX-1 versus COX-2 and getting even into our stroke lecture about the drugs that we use as secondary prevention of stroke. aspirin being the classic example there of a COX-1 inhibitor. So, so this is really a great lecture here to talk about osteoarthritis, but to kind of bring us back to some of the things that we started talking about all the way at the beginning of FPC2 with NSAIDs, aspirin, Tylenol as really good drug examples here for a lot of different reasons. So yeah, I just wanted to make sure I mentioned that point. And then also Lidoderm, right? Lidoderm is like
Yeah.
our friend on the floor.
Lidoderm patches.
Yeah, Lidoderm
Lidoderm
patches are
patches.
great, yeah.
You just have to have areas that you can actually put them on. And that's always the key.
Yeah.
Okay. All right, good job, guys. Thank you.